I'm Dr. Mark Gold, and this is the Gold Standard. Thanks, Bob, for joining me.
It's one of the greatest days of my life to be with you. I'm looking forward to
it. Well, oh, good. You're always kind. So let's go back and just talk about some of the fantastic accomplishments. I'll miss some. I can't cover all of them. They're widely available on the web. But I remember meeting you. I wonder if you remember meeting me.
Oh my God, it's unforgettable. Nobody else I've ever met will I say that to, that when we met, it's unforgettable. But Mark Gold, I can tell you, it's unforgettable.
Well, I remember you were giving a speech. Is that the same time that you remember?
Yes, at the APA annual meeting. And I think I had just come off the podium and I met you in the hall. And
I was sitting in the front row and mesmerized. I mean, I had reported on clonidine, and I sat there and said, neuropharmacological advances are nothing like considering the whole person. And I remember going up to you, and I think
you don't remember what you said. Do you remember what you said?
I said that if I grow up to be somebody like you, I would have had a very successful career in life.
That's exactly what you said. And in my long career, nobody else ever said that.
They thought it.
I don't know about that.
They probably thought it.
That's ironic. But it made a lasting impression on me. And of course, our friendship has been a treasure to me all these years. And your distinction in the field is just spectacular. I don't compare mine to your success.
Great. Well, I'm the one that was on your board. So yeah. Just all I could say was it was always great to come to Rockville. So let's go back, and you're a medical student. When did you decide you wanted to be a psychiatrist?
After the 8th grade, my family moved from a farm in Ohio to Denver. I didn't know anybody there. I didn't have any friends at all, but I went down to the local public library. I walked into the library and they had a little rack of like 8 books that when you just walk in, think about these books. You got all these thousands, but here's these 8 books. And so I looked at this and there was a big black volume there. And I think it was big, and I loved the title, The Human Brain. It was by Carl Menninger. His book, The Human Brain. I was on my bike. I biked back home. I took that book and I read that book from cover to cover. Now, that was an unusual thing for me to do. And I said, I'm going to be a psychiatrist. Never mind a doctor. I'm going to be a psychiatrist. And that was the star that I followed through a very meandering path to get there, but that was my goal, and I did that, and that was very helpful to me. And I can't explain how that happened and why. Nothing else like that ever happened to me before or afterwards. But that was, and I credit that moment with largely being who I am.
So you did a residency at Harvard?
Well, my course of education was unusual. I went to Emory, and I had been a very mediocre high school student, unlike you, I'm sure. And I didn't know that to be a doctor, it was competitive. That I didn't know, and I wasn't competitive. But when I got to Emory, I figured that out. And I became very competitive and did things that were quite remarkable. I was, for example, chairman of the Honor Council. I was chairman of the Publications Council. I was president of my class. My fraternity, when I was playing basketball, my fraternity team won the championship that year in my senior year. I did a lot of things like that were quite striking. I wrote a column for the student newspaper every issue. One of my big things, Emory was segregated at that time, so I was arguing for getting it integrated. And the director of the head of the board of directors came to my father and said, "Can't you get Bob to let up a little bit on that? He's embarrassing us." And my dad said to him, he said, "I think you better talk to him yourself. He's never done anything I told him to do, so maybe you'll get better than I will at that." But anyhow, that's what got me to Harvard. And that was a big deal to me. I went to Harvard Medical School, and then my training was at Harvard also. Now, of course, the more distinguished psychiatric group was at Yale, but I didn't know that when I signed up to Harvard.
It's like apples and oranges. So you're a funny guy. You're always a funny guy. But in Harvard Medical School, did you just think about going to Harvard Psychiatry, or did you look around?
Oh, I applied to 5 places, and I looked around, but it was obvious to me once I was in Harvard Medical School that I would go to Harvard for the rest. But it had nothing to do with drugs, and it was all about psychoanalysis, and I was ill-suited for that. I had trouble figuring out any kind of a mentor or anything like that for me in medical school. I didn't fit any of the categories, except I really cared about psychiatry and I liked the patients. I was very interested in that side of it. But there was nobody at Harvard Medical School of Psychiatry that I saw was, a model for me. It was in all those psychoanalysts that were so dominant there.
So when you finished the residency, then what?
Well, it was competitive to get into Harvard Medical School, but getting into NIH during the Vietnam War was harder than getting into Harvard Medical School. So I got that one. I got into NIH. That got me to Washington. And when it was time to look for a job, there was a crime epidemic in Washington that became a national issue. Richard Nixon made an issue by calling Washington, D.C. the crime capital of the nation. I had worked one day a month in a prison in Massachusetts, my residency, and I really liked the prisoners. I was very interested in that place. And so I decided I was going to do something to make a contribution to the problem of crime in Washington, D.C., which was a big deal. Lyndon Johnson, who was president, had a crime commission about it. It was a very big issue. So when I got there, I went to the Department of Corrections, and very shortly, I got an idea that maybe there was a connection between heroin use and crime. And so in the summer of '69, I got some students from Washington College to go down to DC jail and take urine samples. And we found that 44% were positive for recent heroin use. And when we looked at what year they first started to use heroin, it fit with the rise of crime absolutely perfectly. And then the question was, what do you do about that? And that was my beginning of my interest in treatment. And I right away got involved with Jerry Jaffe and Vincent Dole and got into the methadone. Literally, Mark, I was give the first dose of methadone 6 weeks after we finished that survey of the DC jail. And it became a big program called the Narcotics Treatment Administration. We treated 15,000 heroin addicts in the course of 3 years, dropped the overdose deaths from 70 in a year to 4 in that period of time. The crime went down, and other things happened too, but it was a wonderful program. And the joy of my life was that program, Narcotics Treatment Administration. I never had anything like that before, but I got promoted, I guess, to the White House, you'd say. In some ways, it was a loss for me. But the reality is I couldn't have kept it up because there was a lot of conflict about it. And the mayor who had hired me was my I mean, my mentor and Walter Washington, a wonderful person, was going out, and Marion Barry was coming in, and I wasn't going to have a job anymore in that, and so that's how I got to the White House. But the love of my life was that DC program. And we published in Science Magazine, New England Journal of Medicine, everybody. I mean, it was an incredible public health achievement.
I think I read that paper in the New England Journal. The paper basically, the Association of Substance Use and Crime, and then subsequently you reported on how treatment really works.
Yeah.
Is that true?
Oh, yes. Well, there was a group
I converged them.
Yeah, that's right. Well, that's right. And there were a group, there were no older experts on drugs. We were all kids. And the fact that there wasn't a field there before sort of opened up all kinds of opportunities to younger people, which I was at that time. And that was very important. It was a fun group of people who were doing this and creating this this whole field that is now a major part of medicine.
Yeah, it is. But I mean, it isn't just you had the vision to think about treatment, and then right away you chose a treatment that was very controversial.
Oh yeah.
Dole and Nicewander are in New York at Rockefeller. Many people considered it heresy and that addicts couldn't possibly be treated. And here they were giving methadone, and you work with them.
Oh, I did. When he came to town, he came to dinner at my house, and when I went to New York, I stayed at his apartment. Absolutely. Vincent Dole talked to me about how the heroin addicts, once they get on methadone, they don't want to use heroin anymore, and they straighten out their lives and go on all these wonderful things. And he didn't tell me about the problem of methadone overdoses. And I learned that the hard way. It was almost cost the program. And the other thing he didn't talk about is how most of the people drop out of the program. My image was they're just going to stay there forever. And some do, or at least stay until they are off of it, all drugs. But a lot of people on methadone were still using drugs. I mean, it was a lot more complicated than Vince led me to believe, a kind of simple way of looking at it. But he changed the world, and it was very important, Mark, that just by happenstance that Richard Nixon was president at that point. So it was very interesting that methadone appeared as a Republican idea, which is very odd to think about it in terms of the politics of it. But it was. But it also meant that John Mitchell, who was the head of Justice Department, and he was not, you would expect at that time to be hostile to methadone, but because we were doing it in Washington and I was associated with that administration, he approved it. So that was a very big deal. To get methadone approved. When we started, it was a new drug approval, and it was not approved by the FDA for widespread use. So it was a lot of lucky things happened to make that happen and make that.
Well, you made a lot of good choices, like even taking the job at the White House. I mean, does that mean like the job where you were the first drug czar?
I was the second drug czar. Jerry Jaffe was the first. He had 2 years and I had 2 years. It was complicated because there was no federal activity on the demand side. We'd had a heroin problem in this country at the beginning of the 20th century. And it was a big problem. And it was solved entirely by law enforcement. It was made illegal. It was illegal for doctors to prescribe heroin to people with addiction. Lock them up. There was no other thing but law enforcement. And then we had another heroin epidemic, a smaller one, during the Korean War. And that was 20-year sentences for people. It was totally law enforcement, no treatment whatsoever in that. What was new in the epidemic that started in the late 60s was a treatment component to what was going on. And that all went on in the Nixon administration, which again was very ironic to think about it. It was contrary to the sort of the political thinking that was going on, that all of the directions in federal government that had to do with treatment and prevention came out of the Nixon administration, which is just, people can't understand that, can't believe that. But that had to do with timing. It didn't have to do with politics. And Nixon and John Mitchell, as Attorney General, were very positive about that because they saw the results.
Did they also start NIDA, or how did you get that job?
Yeah. Okay, here's the story. The big decision was called the Special Action Officers Drug Abuse Prevention, SAODAP. 71 it started. Nixon got together with the Democrats in the Congress and established a new office called SAODAP that was all the functions of law enforcement, prevention, treatment, and research. Those were the three components were put into one called the Special Action Officer Drug Abuse Prevention, but it had a 4-year life. It was just to get started. And then that would evolve into NIDA, which was going to be part of HEW. So it started off in the White House for 4 years, just 4 years. Jerry Jaffe was head for 2 years, and I was head for 2 years. Then I became the head of NIDA because NIDA just incorporated, the staff moved from the Special Action Office to the HEW in 1973. And that was a very big deal to do that. But it was completely bipartisan. There was no disagreement whatsoever. I think the original Special Action Office bill went through the House and the Senate with maybe 2 people who didn't vote for it. Virtually every Republican and every Democrat voted for that. It was no contention at all. And I remember how it happened, the legislation. The Democrats controlled both the House and the Senate, and they were as enthusiastic as Richard Nixon was about it. It had no political baggage whatsoever with that, no opposition.
We had a huge drug problem, and the only solutions were going to be invent new treatments, develop treatments that worked, change policy.
Yes, but there was no treatment before that, really. I mean, it's very interesting to think about how new that idea was, and how important it was. It was a sea change. It was a whole different way of thinking about things. And of course, it became a career, and research was, which you were always a leader in, was so important in that activity. And that was the National Institute on Drug Abuse. But the original NIDA was not part of NIH because everything that's now in SAMHSA that has to do with treatment was part of NIDA. The research budget was 20% of my budget. 80% was not research at NIDA. Now, of course, it's all that. So people don't realize what that history is over the course of those many years.
I mean, you started with opioid crisis, and you had methadone, but you didn't have naloxone.
No, that's right. No, we didn't have naloxone. The idea of an opiate overdose reversal, I don't think was a part of the picture at that point, right? But overdose deaths were a big part of it, and that's one of the main things that got people's attention. Was the deaths. That was very dramatic. And of course, all the heroin then came from poppies grown in Turkey that were processed in Marseille. And one of the things that Richard Nixon did right away was use the full force of the US government to shut down the poppy fields of Turkey and close up the laboratories in Marseille. And that was very important too in the reduction of things. But now, it's a whole different world. You know, poppies are all over the place, mostly in Europe, in Asia, but you can grow them anywhere. But what's big, of course, now is synthetics. The whole idea of drugs coming from plants, like cocaine came from a plant, marijuana was a plant. But what's happened, it's become synthetic. And now you can make it anywhere. You don't have to have a field and farmers and all those sorts of things to make the drugs. We had no idea of that at that time. The big synthetic drug was barbiturates at that time.
Mm-hmm.
And there were a lot of overdose deaths from barbiturates. The movement to benzodiazepines changed that a lot.
So what do you remember about your career at NIDA? Like, we all owe you a debt of gratitude, of course, because all of the treatments and research that came out of NIDA started with your work.
Yeah, Jim Callahan was working with me there, and he started the physicians program, Pioneer Physicians, and really began the field of addiction medicine. Did just a wonderful job with that. All of that development, academic development, came from NIDA. We hired a bunch of doctors all over the country and got them trained together and worked together and really started the field. And I give Jim Callahan, a lot of credit for what he did. It was a very exciting time with lots of opportunities there, but there were plenty of controversies too in all of that. It was a very happy time and a very proud one for me. But it was a lot of other people who were very involved. Mostly young men, not many women were in things at that time, and everybody was young.
Well, we didn't have, as far as the clinical services, still for many years, we had no such thing as addiction psychiatry training or addiction medicine training.
Yes.
You used to train people by having them work with you. It was really an old-fashioned method.
And also, it was part of psychiatry, which is very interesting. And that was a problem. I was always a fan of getting addiction medicine out of psychiatry so that people who were not psychiatrists could get into addiction medicine. That was very important, especially important for the recovering physicians who were very important in this development. Most of them were not psychiatrists, and it was very important that they get involved in it. So that was a big deal. And also within psychiatry, addiction was a very low class kind of thing. As long as we were in psychiatry, we were in sort of a wasteland that was very, very bad in mental health for a very long time. So sort of breaking free of that was very important for the.
Yeah, no, I remember we're here in the Hatherleigh, and I remember Fred calling me in 1980s, early in the 80s, and saying it was about time for him to expand CMEs and education into addiction. And I said, "Are you sure?"
Yeah, right. Yeah.
It was very hard.
Yes, it was. It was hard, but it was wonderful, and it opened up so many opportunities for so many people like you and me over those years, and in dealing with that modern drug epidemic that is so prominent now, and is going to be with us forever. The idea, I think it's sort of sad, but still kind of humorous, that people think they're going to end addiction. No, they're not going to end addiction. And we're going to be dealing with this problem for the rest of eternity because the drugs really do hijack the brain. They take over the pleasure centers of the brain, and people like it a lot. The change in the brain that comes from addiction is not going to go away. That has to be managed for the rest of the life of that person. That is very striking. You start off and it's just harmless fun, and then it ends up with being enslaved. I call it chemical slavery. and it's voluntary that people get into it because they don't think about where it's going to end up. And not everybody does end up who uses it, but an awful lot of people do, and it takes over control of their lives. It supersedes everything. The poorest person, an addict in the world, is paying cash for drugs, which is an example, evidence of just how powerful that is.
You've tried to help everyone get out of this notion of the drug of the month or drug of the year or drug epidemic of the year and think about it as a single disease and a common neuroanatomy. Where did we go wrong in not accepting?
Let me tell you something about that that is amazing. All of our diagnoses are substance specific. None of our patients are substance specific. That sounds like a problem to me. And then you talk about every single medicine is substance specific. You know, we're talking about the fentanyl problem now, as if that's the problem. Well, it is a problem, but nobody's dying of fentanyl without other drugs. The average is 2 to 4. The maximum is 13 other drugs at the time of death. It's a polydrug problem. It's been a polydrug problem from the beginning about that. And people were not focusing on that. And the whole diagnosis thing is very cockamamie. And people now think that the big problem is Mexico and China. Look, the problem is the money the drug users are spending for the drugs. If you closed off Mexico entirely and China, you wouldn't change anything because fentanyl is easily made anywhere. It doesn't have to be made in Mexico. It's convenient in Mexico, and they do a terrific job, that criminal operation. But the money is what drives it. It's the money from the drug user. Every drug death, the poison was paid for by that patient, that person that day. And people don't realize that. They don't think about that. They think about the Mexico and China. No, they're bad. I don't have anything good to say about them. They're criminals. There's no doubt about it. But if we're going to stop the problem, it's not going to be by changing them. As long as you have $750 billion a year on the table, there are going to be plenty of entrepreneurs who are going to come collect that money.
So I think that's a huge contribution. And the selfish brain, I remember you asking me to review it and how proud I was of it. See, it was a successful book in getting the word out, at least about the common neuroanatomy and how drugs have so much in common rather than dividing them into parts.
That's absolutely right. No, and you have been a leader in that all that time. And
I wish I could write as well as you. You know that.
Oh, I don't think I write very well, but I've enjoyed the books too, and think that it's good that somebody has, like you, especially you, have found them to be of any value. Another book I wrote, people didn't like that because they didn't like to think about marijuana as a gateway drug. That was, I was death for the marijuana people by using that term.
That's interesting. Yeah, I understand that. But today we pretty much think that teenage alcohol, tobacco, vaping, and cannabis are gateway drugs.
Of course they are. That's absolutely true. They didn't like that phrase.
It's brain training. If you talk about tobacco, of course you have to start them young.
Yeah. Well, that's a very interesting thing to think about. And that's my passion now, is what you're talking about. That 90% of people began before the age of 18. And the younger this person starts, the more likely they are to have be dependent on a drug addiction, substance use disorder. But the thing that is new to people is to think about the sort of the old way of thinking about it is it's normal for kids growing up to try drugs, and you want them to not use too much, and this and that, whatever it is. But we've normalized kids trying drugs, experimenting with drugs. Well, the experiment is that drugs really work. And a lot of people really like it, and they really like it a lot. And it's also a reality that the teenage brain is incredibly vulnerable to that liking and losing control of that. And so, what my mission is, Mark, is now is to emphasize the fact that to denormalize drug use, and instead to normalize kids not using drugs. And the great contribution that I feel I have made to this is to discover the fact that there is a 4 decades long trend in this country of more and more youth using no drugs until we at IBH got going on this. Studies, all the studies and the monitoring the future studies and the household surveys talk one drug at a time. What's happened to cocaine? What's happened to marijuana? What's happened to this and that? They never looked at what happens to no use. Well, in 1983, the high school seniors who had never used a drug in their lifetimes, high school seniors, was 3%. 3%. Last year was 37%. Yes. People don't know that. That's an incredible change in youth behavior in that. And so my goal is to have kids and pediatricians and parents and teachers and everybody else know that it is not healthy and normal to use these chemicals in adolescence. And as we call it one choice, the one choice is just not to use it all and to denormalize kids using drugs. And I think that is, to me, that's the future, to do that, to keep building. We've got a trend, we just keep building that trend. And the people to build it are the kids who are not using. The parents of the kids today were much more likely to use drugs. And so they have a trouble believing that kids don't use drugs now. But it's a very common experience. And that, I think, is really important to get across about that vulnerability, that special vulnerability, protecting the brain. But there's a lot of things working for us because kids now are really concerned about their brains. Nobody, when I was a kid, was talking about their brains and their brain health, but they do now. And I think to really capitalize on that is very, very important.
Well, I mean, that was on my list. I'm glad that we got to talk about it. I think also even just the monitoring the future, asking the questions, if you don't use any drugs, it came from you.
Yeah. Well, that's right. I was the first one to get them to do it. They never published it. And by golly, they still don't do it right. What they say is there's this growing percentage of kids who don't use any alcohol, any nicotine, and any marijuana. Well, that's good. I like that. That's a step forward. That's very good. But they won't say, or any other drug. And what they say instead in a footnote, they say, and if they don't use those drugs, they're not likely to use any other drugs. That's true. So in a sense, they're saying it right, but they don't say any drug. They say those 3, those gateway drugs. And I want them to say, no, any drug. And because the truth is that if you're not using any of those drugs, the likelihood you're using any other drug is very low. They're correct about that.
Yeah.
But the way it's said is important to me. And I was the one who started monitoring the future when I was in the White House. So I set that first contract up in the University of Michigan. I'm very proud of that.
That's what I had right here. I'm very proud of it because longitudinal data is very hard to support.
Yeah.
I had another major accomplishment that changed what I do too, and that is your interest in impaired health professionals.
Yes.
As you know, we trained a lot of them ourselves.
Yes.
You
God bless
probably
them.
Yes, you and I had stints on boards of medicine to try to get people who were in treatment and recovery their licenses back so they could go back into the field. Many of them we trained ourselves in addiction medicine, and
they're passionate about it, and that's wonderful.
They have the lived experience plus the intellectual background if they do their fellowship.
They know
but your work your work again, you talk about longitudinal with Michigan. You have one of the only 5-year outcome studies that people refer to, and that's your studies on impaired health professionals.
Yes, about the year 2000, and because of that year, and sort of thinking back, and I was already old then. I was thinking about this most stunning thing about addiction treatment is relapse. Is how high percentage. I did a study of a wonderful methadone program, and how does it work? Well, about half of them are gone by 6 months. And by the end of 5 years, it was 15%, including those who came back. So 85% were gone, and none of them went out by going off the drug. They went off on methadone, which meant they went left with a habit in the program. So my question was, how good could outcomes be for treatment? And I had, like you say, I had patients in my practice who were doctors who were going through the physician's health program, and I saw they all got better. So I recruited Tom McClellan, who's the world dean in treatment evaluation, to do the first national study of the physician's health programs in the United States. And we found 16 programs that we worked with and got about 1,000 doctors in that and followed them, of what happened to them. And what we found is, 95%, 98% completed successfully in 5 years. It was amazing. But what happens to the doctors, people don't understand this, is once their doctor is diagnosed with a substance use disorder, then his license or her license is conditional on their not using drugs. And that is enforced by random drug testing. So the doctor for 5 years, when he or she gets up in the morning, has to check, do I need to be tested today? And it's on a random basis for 5 years. And any missed test or any positive test, they are hauled out of their practice and back into treatment, residential treatment. So it's a very consequential thing that they show up for the test and they do it that day to keep their licenses. This is very strict, and the consequences are very severe for them, and it's for 5 years. And they do it. And part of the reason they do it, Mark, is because they're immersed in a culture of other physicians who've been through the same thing. It's not something that is no doctor like you and me would ever come up with a thing like that. It's too severe. But the reason it happened was because the doctors who did it were doctors in recovery. One of the leaders of it said to me, getting a doctor's attention about his addiction is very difficult. It usually requires hitting him over the head with a 2x4, and once is now usually not enough to do that. Now, no self-respecting psychiatrist would ever talk like that, but he could say it because he lived it. And that's why it's so different from that. But then the other thing about that study that I want to emphasize to our audience here, because it's so striking to me, we asked the people, now that's 5 years after their last test, 5 years after that, we got about population. And only one had gone back of the sample. It was wonderful, it's stable. But the question we asked was, what one element of this was most important to your recovery? That was the question. Of all of the drug testing, the treatment, everything else, what was the most important? Well, treatment was very high. They singled that out and said, twice as high as treatment was the 12 steps, AA and NA. Now, most people in our field have no clue of the importance of AA and NA. They do not understand it. The professors are worse than the students about AA and NA. They'll talk about the community support or something like that. They don't want to say 12 steps, but it's the 12 steps. It's not community support. It's a very specific program that is started in the United States in 1935 by a doctor and an unemployed salesman in Akron, Ohio, for God's sakes. And it's a gift to the world. But it's very important to recognize that that's what the doctors said in that study, and they rated it twice as high as treatment. Come on.
Yeah,
That's data that it's hard to overlook that. But it took me 20 years in the field to figure out how important AA and NA was. I've gone to a lot of meetings, and I've never gone to a meeting I didn't learn something from. There's a wisdom in those meetings that is quite wonderful, really. And people will go to a meeting, they say they don't like it, and they drop out. Hey, if you've gone to one meeting and gone to one meeting, they're all different. There are thousands of meetings. Right. You find one that's for you. It's wonderful. And I'm proud to be an American for a lot of reasons. But one of the top reasons is the gift of America about AA and NA. No money involved, no licenses, none of that accreditation stuff. Nobody's making any money on it. It doesn't cost you anything. The poorest person goes to the same meetings the richest person does. There isn't anything else like that in the country.
And you can get it if you work the program, you can get a sponsor. And there's do your own crisis work. Oh, you're not going to get a psychiatrist in the middle of the night.
Exactly. And the whole group will rally around you. And it's a wonderful thing. And it's also about living a good life. The thing that people don't understand, and the more smarter they are, the worse it is about this, is that people who are in recovery are different people than they were when they were using. It's not just that they're not using, it's they're a different person than they were when they were using. And that's because of the negative effect of the addiction on the character of the person. And recovery creates, especially through the 12-step programs, creates a different kind of person, a more generous person, a more thoughtful person, a more caring person. It's very interesting. It's not just that they've stopped using. That's right. And that's important. That's a beginning step. But it's a different, better person. And that took me a long time to understand that.
Well, that's really important because when you look at some of the treatments that are proposed, they only work as long as the person's taking them because they're not treatment per se. I mean, you give somebody methadone the day they stop, their risk of relapse is the same as when they started, or Suboxone. I had a recent piece myself about why don't people take medications for alcohol use disorder? And I go like, well, it costs this. They see this as a benefit. Where's the fellowship?
Yeah.
Where's the glue? Where's the remodeling? Where's the chance for new learning?
Medication can be very helpful. I don't have any problem with that, but there's more to it than the pill. The other thing that's interesting to me, I was talking to some leaders at National Institute on Alcoholism and Alcohol Abuse, NAAA, and they want to get pharmaceutical companies interested in more treatment for alcohol, which I think is interesting. But the problem they've got is how do they measure success? And what they want to measure is drinking days. How many days were you drinking? And they say if they get a 20% reduction in drinking, that's called efficacy. Really?
Well, it's a challenging at this particular time, and you're the one that told me that, was everybody else is being told to drink less, that drinking is dangerous. Yeah. And somebody with an alcohol use disorder is being told, everybody's told to stop. Regular people, they said, you should stop if you're not drinking. You shouldn't start. And the other people are drinking less. That's not an outcome. It's an interim measure.
But it's a terrible thing people talk about evidence-based treatment. And what they're talking about is reduced drug use for some 6 months or something like that. This is not what we want. And I asked the person, why do you choose that? He says, I can't interest the pharmaceutical companies in studying because they can't reach that goal. So you've got to move the goalposts. And you move the goalposts so they don't have any meaning anymore. And then you call it evidence-based treatment.
But I mean, you manage that endpoint in your physician health study.
Yeah, the goal is, first of all, not using, but it's also being a better person. But you can't sell that to the smarter people in this country, in this field. I guarantee you that. Even you can't sell that.
So when I think about the physician study, people will say, well, that's more proof about DuPont's notion that there are more than one type of addiction, but especially late onset is different and maybe more treatable than early onset.
But it's
Like if
saying
you're,
stop drinking.
yeah, exactly.
It's not going to work out to cut down. That's
Yeah.
not going to work. You can try it over and over again. It's not going to work. Uh, but it's also true that when I'm talking about people who are addicted, who have to get a substance use disorder, you have to have negative consequences from your use. If you have no negative consequences from your use, you're not going to have a substance use disorder. The disorder has to do with repeated negative consequences. Now, once you have repeated negative, there are a lot of people who cut down their drinking. That sure you can cut down, but not the one who's lost control. That's the one who doesn't cut down. Yes, it's fine to cut down when you don't have the problem, but cutting down is not going to be helpful to people who have lost control of it. And we know that about cigarettes. People don't really talk about cutting down on cigarettes. You stop cigarettes. And they also know
It was quit attempts.
Yeah.
We used to keep track of quit attempts, but
Yeah.
you would actually try to get them to quit. We understood that you just kept trying as a doctor.
Yeah.
Now, there is such a thing as treatment-resistant depression. I'm sure there's such a thing as treatment-resistant opioid use disorder. We all have a limited number of treatments, but for sure in tobacco, and you led that way on that, it's quit attempts. We try to help them to quit. We don't say, well, you should smoke less. You made some interesting, I just remembered when you said cigarettes, I remembered you told me probably 30 years ago that it wasn't medication that helped us out of the tobacco epidemic. It was people quitting as a result of health concerns, people and stigma.
Responding to social pressure to stop.
Yeah, stigma, you said. Stigma isn't always bad.
No, it's good. When I was working at HEW in the beginning, the conference tables, at every place was an ashtray. Every place was an ashtray. You couldn't see the person on the other side of the table for the cigarette smoke at HEW. And people can't imagine if that was ever the case. Well, it was the case.
Yeah, well, I mean, we have medication-assisted treatment for smokers, of course, but they were a small part of the successful quit attempts.
But George Kolodner is a friend of mine, and he's the heart and soul of that effort. And you're talking now about at this time where cigarette smoking, and you've got people who are still smoking. That's a different population.
Oh, well, they probably like it. It gets back to your other work on dual diagnosis. I mean, who's left are people that are depressed and smoking, or schizophrenic or psychotic and smoking, or this and smoking.
It takes more doing, that's for sure. But we also know about the smoking. It's so clear that even one cigarette is very dangerous for a person who's quit smoking. Everybody knows that. And yet with alcohol and drugs, people have a hard time knowing it. I don't know why that is, but it is true.
Well, you probably have an idea about why that is.
I don't know. There's a resistance to the idea of non-use, is what I think. That is the problem to it. And I don't think smokers who stop think about they don't. Well, that's just a tautology I've come up with. But I think people with alcohol use disorder want to be able to be drinkers that don't have problems, and it's hard to get them to realize that option is biologically out. That's not going to work.
So that's the bad news. You have never been afraid to give people bad news.
I don't know. I don't recognize myself in what you're saying. You give me much more credit than I.
But it is true that, I mean, we've changed notions about hitting bottom. It may have been easier in a way if somebody really had a terrible consequence. It might have been easier for them to go to rehab and give up drinking or drugs.
Yeah.
We've raised the bottom a lot now, and it's harder.
Yeah. The amazing thing to me is now the most likely outcome from a successful recovery of a person who has an drug overdose, is to go right out and start using it again.
Oh, definitely.
Uh,
Well,
uh,
even for cannabis, there's the cannabis vomiting syndrome, and the as they've increased THC concentration, it's more common, and so the literature has the treatment for that is to stop smoking cannabis,
yeah, yeah,
and it's like 90% say, "Well, I'll vomit then."
yeah, right. That's the hijacked brain. Well, the phrase that is used by people in recovery is that you just can't imagine life without it. It's become such an integral part of who you are. I guess is the way to think about that. I think of myself, Mark, as a student of addiction. And my life's work is to learn about addiction, and it's never over. It isn't that I'm going to graduate and get a degree. No, it's going to be an ongoing process, an adventure, and I love the adventure, and I have a very clear sense that in 5 years from now or 10 years from now, people will be flabbergasted by my stupidity about all kinds of things as people learn more about it and all. But that's all right. It's a process, and it's a process personally. It's a process for our society, as I think about it. And I think it's a wonderful mission, and it has been a tremendous adventure for me. And one of the big things, working with people in recovery is a terrific, wonderful experience. But working with people, including you and other leaders in the field and other people in the field, not necessarily leaders, is a terrific gift to me, and that I really love and am so grateful for.
Well, I can't speak for all of your mentees and friends, but just for myself, we cherish your insights. We love your passion. I love your stories. And when you were talking about Richard Nixon, I was thinking, did he know that you had a letter from Martin Luther King to go to Africa?
No, he didn't know that. When Martin Luther King died, a part of me died. That was a relationship that was very precious to me.
Well, you're precious to all of us. I thank you for everything and I have a big long list of your contributions to my work. They're infinite, but your friendship and being on your board for all those years are the highlights of my career too.
Thank you, Mark. Bye bye.